So our next speaker is Dr. Lakkireddy, who will tell us about the clinical results of the Lariat device. DJ.
Thank you, Jackie and Matt. Well, obviously, the device that we're going to talk to you now is not the most studied from a randomized control standpoint, but I think it's a pretty exciting device that has some very interesting data from both retrospective as well as prospective studies with a large ongoing randomized control trial from an arrhythmia perspective. So these are my disclosures. And so the Lariat suture device was approved on a 510K premise for delivery of a suture or a knot to approximate or ligate soft tissue with a subsequent update to this particular device in 2009 and 2014. So obviously, Lariat came about at a time where Watchman is being actively studied in a clinical trial, and there was a huge unmet need and a gap that needed to be embarked upon, and as a result of which, very quickly, this device became one of the most popular off-label users in the country. And then long before you realize, there were close to 100+ centers that actually were using this particular device. And along that, we made some very interesting observations, and we reported some of these. So it's an epicardial device. You gain an epicardial axis, a dry pericardial axis, and then you do a transeptal puncture. And you have a large inner magnet that's attached to a wire that you advance it towards the tip. You can use that balloon which would help you as a marker. And then you advance another smaller magnet from outside through the epicardial sheath. These two magnets attach to themselves. And then you pass a lasso that has a suture around it. And you pass it over the neck of the left atrial appendage, and then you tensure it while the appendage is full. Unlike the older surgical cases where the patient was on the pump, and then you had a flaccid left atrial appendage that you tried to tie off with the help of a suture. So this is quite different in the way it works. So one of the reasons why I think this works is because of the self-retaining suture when the appendage is full, and then the 2 or 3 times of tensioning that happens to really reduce down the tissue to the least possible diameter approximates these tissues together. I think that's what is really the biggest reason why Lariat works much better when a manual ordinary suture doesn't work. And this is what happens. So you have the appendage closed off. There is no more appendage left behind. And as it undergoes remodeling changes, ischemic necrosis, it basically atrophies and then it disappears. So you not only mechanically exclude it, you actually eliminate the entire left atrial appendage. That being said, there are perhaps certain implications to how you talk about and what are the effects of this particular device. Right, when you really take an epicardial device, an excluder, you're completely eliminating it from the systemic circulation. That may have impact on not only on the thromboembolic aspects but also on atrial arrhythmias, but also on neurohormonal regulation and the cardiac reservoir function of the left atrial appendage. So the epicardial devices really provide us a different perspective to the entire cardiovascular participation of this particular structure that is mostly known for its role in the systemic thromboembolic aspects of that. So let's look at some of the Lariat outcomes data. One of the first papers that came out was from Chris Partis. Their early experience clearly showed that at the 30-day closure was about 95%. At 1 year, they had 98% because some of the smaller leaks that are less than a millimeter or so closed off on their own. Overall performance of this device was pretty acceptable. So over the next few years, there were experiences from different smaller series of publications that came about where the ability to close the LAA acutely was ranged anywhere between 95 to 100%. And the follow-up data clearly showed that the overall closure rates range anywhere from 80 to 95, 98%, depending on which series that you are looking at. So it definitely works. So one thing to remember in this particular case is the type of leak that you get in a Lariat device is mostly central because it leaves behind a very small gap right in the center, like what I described this as a gunny sack effect, which can be very easily closed with the help of an ASO closure device. And Matt has published a series, we have published a series, and this is something that can be easily done, unlike an endocardial occluded device, where you have a leak that is mostly eccentric in nature and is oftentimes harder to close. So this is sort of the example of that. This is what we describe this as an edge effect, where you have a leak around the sites. So if a 5 millimeter leak is an acceptable outcome for all the endocardial devices, I think Lariat has a much better closure rates in terms of if you really define it by the size of the leak. Of course, every device have their own definitions of what they define as a leak, and this is something that I think we as a field need to really redefine what is acceptable and what is not acceptable. And so this is a nice paper that looked at the role of Lariat device in left atrial, in actually stroke patients who are at high risk for stroke. This paper from Horst Sievert's lab clearly showed Lariat actually helped to minimize the risk of stroke by about 4 times compared to that of the standard estimated event rate in a high-risk population who cannot be on oral anticoagulation. So the biggest issue that I find is when there is a lot of pericardial fluid out there, it's very easy to put a needle in there. But I think the trouble comes in when you have a dry pericardial space and you involve a procedure that really requires a needle. That's where the problem comes in. So the early experience was ridden with significant complications as the field itself was really not prepared to embrace this particular procedure in the way that it really evolved itself. The tools were very rudimentary and they were really not refined. So the large bore needle, in our opinion, was actually a bigger problem that was responsible for most of the issues. So when you really replace and rethink the process and replace it with a micropuncture needle, you have a much better safety net there because there are lesser penetrating forces, less shearing force, as a result of which you have a lot more control over the needle, and then the overall perforation rates dramatically came down. And this is something that we actually adapted very early on, either a long micropuncture needle or a needle-in-needle approach that will really help you to stabilize the outer aspects and then get into the pericardial space without creating a large shearing force. And this one simple step itself brought in a dramatic difference in the complication rates in the entire procedure. So you went down from 29 complications to 9, I mean from 10% to 2.2%. So these are all things that I think every device goes through in its evolution and development of clinical evidence over a period of time. So the next generation Lariat actually is much bigger, 45 millimeters. It has a marker. It doesn't do the helicoptering that typically happened with the older device, so a lot more stable. So the shearing effects on the appendage while closing it was definitely dramatically improved. And we also figured out that by using colchicine, you can actually minimize the risk of a sort of subacute and chronic pericarditis that was noted in some of these cases. And that definitely improves the overall safety profile of this particular procedure. So when you really bring these two things together, using a micropuncture needle and using colchicine, in addition to appropriate, careful selection of patients, the performance of this particular procedure seems to be a lot different from the early experiences that a few groups have reported early on. So that's basically the colchicine effect, where you can minimize both the pericardial effusions as well as the late pleural effusions that were earlier published. So obviously there was an early surge of complications, partly because of the relative inexperience with the whole process. And as we gained more experience, the overall complication rates of the procedure came down to as low as 1.4%, which is pretty good. So when you look at the published safety literature of more than 50 subjects, I think the cumulative complication rate of 180, close to 1,200 Lariat reported procedures was about 2.7%. So what happens to these little stumps? I think the stumps oftentimes are electrically inert. They really don't have any electrical activity through them. As you see here in this particular case, this is a post-Lariat ablation case that came in. That even though there is a little stump, that little stump is electrically dead with a small neck out there. So from an electrical standpoint, it actually works really well. So this is our long-term 5-year data follow-up. Those patients who had a Lariat compared to those patients who could not be part of the study were also sequentially followed for over 5 years. And what we found was there was a significant reduction in the overall systemic thromboembolism as well as major bleeding and mortality. Again, this is an observational data set. Obviously, we need a randomized controlled trial, provided there are patients to be willing to be randomized for this kind of a study. So a quick bit on arrhythmia reduction. I think this is a huge area that's of great interest for electrophysiologists. Once you tie off the appendage, the overall arrhythmia burden seems to go down, and there seems to be significant electrical remodeling because you change the properties of the left atrium. So there could be a potential benefit in terms of arrhythmia burden reduction. And that's exactly what we saw in our LAAO-AF registry, which helped us not only reduce the atrial volume, but also decrease the overall recurrence of atrial fibrillation by more than 26%, which is a pretty important feat. Neurohormonal regulation seems to be another important piece. I need 2 more minutes so that I can complete a couple of important topics. So this is actually a very fascinating area that I think really redefines how epicardial ligation systems really are going to play a bigger role. So when you really look at the left atrial appendage, the ANP is one of the biggest neurohormone that is attributed to be arising from the left atrial appendage. And when you really impact the ANP, there seems to be an effect on not only on the sodium-water metabolism, but also on the RAS, glucose, lipid metabolism that is relatively not well understood. I mean, this is all a very nascent area that really needs further exploration. So what we found was very interesting. So not only the ANP levels and BNP levels change, the adrenaline, noradrenaline, aldosterone, renin levels actually seem to have a much more long-lasting downward trends, which perhaps may explain some of these changes in the systolic blood pressures and the diastolic blood pressure changes in these patients. And so it's very common that we see patients after a Lariat or even an AtriClip procedure that their overall requirement for antihypertensive therapy is significantly lower, and oftentimes we really have to cut them down, and some patients even come off of their antihypertensive medications altogether. So a very provocative observation. Perhaps some of you guys out here that are involved in renal denervation, maybe this is worth studying in patients who are recalcitrant AFib with hypertension that is poor to control on antihypertensives. So AMAZE, I'll wrap this up with, is a randomized control trial comparing a AFib ablation along with left atrial appendage ligation compared to ablation alone. So this is a multi-center trial. Right now we have about 50 centers enrolling. We are at 200 patients. The phase 1 safety data looks very good. FDA gave us the clearance for this to proceed forwards with the phase 2 enrollment. And the enrollment seems to be going really well. So perhaps by 2019, we may be able to come out with the results of the study, which is really going to redefine how we're going to take care of patients who have non-paroxysmal atrial fibrillation, because the left atrial appendage seems to play a much bigger role in arrhythmogenesis and maintenance of arrhythmias in these particular patients. So I think with that, I will wrap it up and take questions if there are any.
Thanks, DJ. Thank you. Can you hear? There we go. Thanks, DJ. Great presentation. I have a question for you. So I have a question about, let's say, Monday and a question for 5 years from now. So on Monday, you're seeing a patient in the office. Which patient will you treat today with the Lariat device outside of a clinic, outside of the AMAZE trial, as opposed to using the Watchman or enrolling in a clinical trial?
All right. So from a clinical studies, from a clinical practice standpoint, we now have Watchman device available in the market space. So if I see somebody that absolutely cannot be on any oral anticoagulation, that means people have failed attempts of warfarin, Novax, everything else, they continue to bleed. And if they have a viable pericardial space with no prior intervention, my option would be to use the Lariat. And also if they had AFib ablations in the past where they have clearly established that the left atrial appendage is the obvious trigger, and they were unable to isolate the left atrial appendage endocardially, those are the patients that I would like to use the Lariat, offer as an adjunctive therapy. But the rest of the guys, I would say, if they meet the criteria for Watchman, then I will offer them the Watchman.
Got it. So you're saying that the absolute contraindicated patients for oral anticoagulation.
Yeah.
Although we have another discussion. We have seen thrombi after Lariat in those patients, so it's challenging. And then how about, is there any plans to look at event rates, safety event rates for Lariat versus, say, standalone on-pump thoracoscopic AtriClip? And do you think the AtriClip may have similar antiarrhythmic effects as the Lariat device?
This is something that we're actually working on. There is an observational study that we are putting together, comparing the two things. So it'll be interesting to see how this comes out.
Because I think we don't talk about the AtriClip a lot, but I think it's an important option for our patients. Yeah. So thank you very much.
Thank you.
Great talk. Okay, so next up, applause.